كل عام وانتم بخير. We'll discuss today a very important topic, which is about corneal dystrophies. Corneal dystrophies is rare in clinical practice. However, it is common in exams, especially residency exams. Okay, this is the outline of the lecture. We'll talk about history, definition, categories, and classification. Then we will focus on the genetics and clinical presentation of each corneal dystrophy, or the most important corneal dystrophies. Then we will have just touch on the management of corneal dystrophies. So the word dystrophy is derived from the Greek. Dys means wrong or difficult, trophy means nourishment, so it's a malnourishment. In 1890, Arthur Gronau published his classic paper describing two patients, and he called that finding noduli corneae. And later on, one patient had granular corneal dystrophy and the other one macular corneal dystrophy. And the old name of granular corneal dystrophy was called Gronau type 1, and macular is Gronau type 2. Fuchs used the word dystrophy to refer to ophthalmic disease, and he postulated that dystrophy's tissue results from lack of nourishment, hormones, blood, and nerve supply. So what is the definition? This is a very important slide. It's a group of corneal diseases that are usually, it's not always, inherited, they are bilateral, symmetric, slowly progressive, and without relationship to environmental or systemic factors. There are certain exceptions to this definition, like epithelial basement membrane dystrophy is not inherited. And for example, posterior polymorphous corneal dystrophy is a unilateral disease, it's not bilateral. And not all cases of Fuchs dystrophy progress to corneal edema. So it is sometimes not slowly progressive. And Schneider corneal dystrophy is associated with hyperlipidemia. So it's not always without relationship to systemic factors. So this is a very important slide, and this is the definition. Again, this is the exceptions. Epithelial basement membrane dystrophy is sporadic, posterior polymorphous corneal dystrophy is unilateral, and Schneider plus lattice corneal dystrophy type 2 is associated with systemic diseases. During the World Cornea Congress in 2005, it was clear that the classification system for corneal dystrophy was inaccurate and outdated. Many names have been published in the literature, but this was a little bit confusing. So in 2008, the first edition of the International Committee of Classification of Corneal Dystrophy was published, followed by the second edition in 2005. And this is the main reference of our slide today. And some pictures are taken from this paper. So the IC3D committee designed a template for each dystrophy, which includes the name, alternative names, genetic information, onset, course of the disease, signs and symptoms, light microscopy, electron microscopy, and clinical photograph. So they categorized dystrophies into 4 groups based on the level of evidence supporting the existence of a given corneal dystrophy. C1 or category 1 being the strongest, which is a well-defined corneal dystrophy. The gene has been mapped and the specific mutation are known. In C2 or category 2, the gene remains to be identified, and category 3 there is the corneal dystrophy has not yet mapped to any chromosomal locus, and C4 or category 4 is a suspected or new or previously documented corneal dystrophy, and that the evidence for it is not yet convincing. We will focus today on category 1 and category 2 mainly. So this is the latest classification. They classified it into 4 groups: epithelial, subepithelial dystrophy, and epithelial stromal TGFBI dystrophies, stromal dystrophies, and finally endothelial dystrophies. We will start with the epithelial and subepithelial dystrophies. The first one is epithelial basement membrane dystrophy, which is category 1. It's previously called map.fingerprint dystrophy or Cogan macrocystic epithelial dystrophies. It is sporadic and transforming growth factor beta-induced gene has been identified in 2 families only. It's usually start in adulthood and rare in children. So it affects 6 to 18% of the population, and 10% out of these 6 to 18% present with recurrent erosions. And the clinical presentation, usually they present with either map-like changes or intraepithelial dot opacities or fingerprint lines, which are best visualized with retroillumination, or multiple crowded blips. Blips means الزجاج المعتق. So this is the picture of blips. So management, you have to manage recurrent epithelial erosion if it occurs, or astigmatism, and LASIK is relatively contraindicated. So if you have a patient with epithelial basement membrane dystrophy asking for refractive surgery, the best option is PRK. Okay, now the second dystrophy is Amusement Corneal Dystrophy. This is Alois Amusement. This is his picture. So it is an autosomal dominant. Most of the dystrophies are autosomal dominant, except GMC. They are autosomal recessive. GMC, it is gelatinous, macular, and chit. And the last exception is Leshkonya Dystrophy, which is X-linked dominant. So just remember, most of the dystrophies are autosomal dominant, except few. So the gene is keratin K3 and keratin K12. How it presents? Usually asymptomatic. Sometimes glare and halos may develop. Recurrent erosion also could happen. They present with multiple tiny intraepithelial cysts, and corneal sensation might be reduced. In light microscopy, you can see these cysts, intraepithelial cysts that contain amorphous material or peculiar substance. So usually no treatment is required, and you have to treat the recurrent corneal erosions, and sometimes a soft contact lens might help. Now, Leshkonya Dystrophy, as I told you before, this is X-linked dominant disorder or disease. If you remember Lesh nodule was described by his father, Carl Lesh, and this picture of Walter Lesh. So they are like ophthalmology physicians or family. So this is the presentation. Usually they present with localized gray opacities in different pattern, hole pattern or band-shaped pattern, feathery or club-shaped. Usually these are like confluent cysts or crowded cysts. They are best seen with retroillumination, as in this picture. The light microscopy showed this vacuolization of the epithelial cyst. Usually no treatment because most of the patients don't have any symptoms, and recurrence is common after corneal debridement. The third one is gelatinous drop-like corneal dystrophy. This is the first autosomal recessive. So I brought these pictures for a reason. This one is, you can see the lesions inside the graft. So this means that the recurrence is very high with gelatinous drop-like corneal dystrophy. And this picture showed corneal vascularization. Most of the dystrophies don't have corneal vascularization, but this one might present with corneal vascularization, superficial vascularization. So it's an autosomal recessive, and the gene is tumor-associated calcium signal transducer 2. It starts early in childhood, and it's progressive, and the recurrence rate is very high, almost 100%. So patients will present with decreased vision and photophobia. It progresses from band-shaped keratopathy into mulberry nodule. And some patients might have a hyperpermeable corneal epithelium without superficial punctate keratopathy. You can see diffuse staining of fluorescein without epithelial defect. And later on, develop into kumquat-like lesion. In light microscopy, you can see the massive amyloid deposition in subepithelial lesion. So treatment is superficial keratectomy, LKB, BKB, with high recurrence rate in few years. So this depends on the clinical presentation and the severity. Soft contact lenses are effective in managing abnormal epithelial hyperpermeability to decrease the recurrence. Now the second group, which is epithelial stromal TGFBI dystrophies. So this is the previous classification was different. They classified into epithelial, Bowman, stromal, and endothelial, but this one classification is different. So they put that transforming growth factor beta-induced gene together. The first one is Specklers corneal dystrophy, which is category 1. Just remember the geographic corneal dystrophy out of these formal alternative names, because it has a clinical implication. It's an autosomal dominant and TGFBI. All the next case, the dystrophies are TGFBI. So it starts in the childhood and it's slowly progressive. So they may present with recurrent erosion, but this erosion will diminish with time. And it is similar to its cousin, which is Thiel-Behnke corneal dystrophy. And we will talk about it in the next slide, but it's more aggressive. So Speckler is more aggressive than Thiel-Behnke or its cousin. They present with geographic opacities at the level of basement or Bowman membrane that might extend to the limbus and deeper stroma. In light microscopy, you can see subepithelial hyaline deposition in a mesenteric stain. And the electron microscopy is the one to distinguish it from its cousin Thiel-Behnke corneal dystrophy by the presence of the rod-shaped bodies. If you have recurrent corneal erosion, treat it, and if you have corneal opacities that affect the vision or causing astigmatism, superficial keratectomy, BTK can be done, and in advanced cases, LKB or BKB, and recurrence is common. So its cousin, Thiel-Behnke corneal dystrophy, just remember honeycomb-shaped corneal dystrophy. You can see the shape is like a خلية نحل or honeycomb shape. Again, autosomal dominance and TGFBI gene. It starts in the childhood and slowly progressive, the same. So all these groups have similar features. It may present with recurrent erosions that diminish with time, is the same. It's similar to Speckler, but it's less aggressive course. So they have solitary flicks that might lead to honeycomb opacities. And in the light microscopy, you can see the subepithelial fibrous tissue in a sawtooth-like surface. And again, the electron microscopy is the one to distinguish it from the Speckler corneal dystrophy by the presence of curly collagen fibers. All of these are MCQ questions that are commonly asked in MCQ exams. So if there is recurrent erosions, treated, or if there is astigmatism or corneal opacity, superficial keratectomy or BTK can be done. So this table summarizes the differences between Speckler and Thiel-Behnke. You can just take a photo of this slide. We talked about it earlier. Now the third one is the Lattice corneal dystrophy. Previously it was under stromal, but now they put it under the group of the TGFBI corneal dystrophies. So lattice means this is the shape of the lattice. So this is the meaning of lattice. It's autosomal dominant TGFBI dystrophy, and most of the patients have decreased vision by the 4th decade. The lattice line of lattice corneal dystrophy starts centrally and more superficially, and then spreading to the peripheral and deeply. The cement membrane and endothelium usually not involved. In light microscopy, you can see the amyloid position that are stained with congolate and are red-green dichroic under polarized light, as in this picture. If there is recurrent erosion, manage it, and it's beyond the scope of this lecture. And if you have opacity that affect the vision or causing astigmatism, dark or BKB can be done. And the recurrence rate is more than granular or macular corneal dystrophy. So this is familial amyloidosis or Meritoja syndrome. Historically, it was called Lattice type 2 or Gilson type. It's not a true dystrophy, but rather a systemic amyloidosis. It's an autosomal recessive disease. They present with a bilateral facial palsy. They have a characteristic facial mask, dermatochalesis, lack of thalamus, cranial and peripheral nerve pulses, dry, lax skin. The lattice line are less numerous than the classic lattice corneal dystrophy and start in the peripheral and spread centrally. It's the opposite of the lattice corneal dystrophy. The fourth one is a granular corneal dystrophy. Notice the breadcrumb pattern or shabura, فتات الشابورة. There is clear interspace between them and it's not involving the limbus. It's an autosomal dominant TGFBI gene. Again, it's a progressive disease. So again, the same thing. It's a granular opacities in the form of crushed breadcrumbs with a clear intervening space. It's usually in the anterior stroma and do not extend to the limbus. And in a Masson trichome stain, you can see hyaline opacities in the anterior stroma mainly. Dark and BKB if visually significant. This is the management. Okay, type 2 or granular corneal dystrophy, previously called Avellino dystrophy. Avellino is a district of Italy where the initial published pedigree originated and came into popular and published uses, but it's now considered obsolete because of the dystrophy is a global occurrence. So now they are calling it granular corneal dystrophy type 2. It's a combination of granular plus lattice, but the lattice here is different than the lattice corneal dystrophy. The lattice corneal dystrophies, they are interconnected to each other, but here it's like a star-shaped. In homozygote patient, they present with early and it progresses faster. And I will show you a picture of a homozygote patient. So it's a combination of hyaline and amyloid deposition because it's granular and lattice together. It's fewer stromal opacities than those patients with granular dystrophies. This picture showed the homozygote patients. It's very confluent opacities. Important to remember about granular corneal dystrophy type 2 is that excimer laser procedure is contraindicated as it might result in exacerbation of granular corneal dystrophy type 2. Now, stromal dystrophy, the third group. The most common here in Saudi Arabia is the macular corneal dystrophy, and it's very important. You notice the macular lesions and the space between them is hazy, and it involves the limbus also. It's autosomal recessive. So this is the second autosomal recessive. The first one is gelatinous, and this is the second macular corneal dystrophy. And the gene is carbohydrate sulfotransferase 6 gene. It starts in the childhood and slowly progressive. It's very important to know macular corneal dystrophy. It's irregular whitish flake-like opacities that involve the limbus and deep stroma down to the decimate membrane. It might involve the decimate membrane. Some patients have thin corneas or guttata might develop. Recurrent erosion is less than granular and lattice. In light microscopy, you can see a glycosaminoglycan deposition with colloidal iron stain. This is a colloidal iron stain. This is in picture C, advanced stage of macular corneal dystrophy. This is a keratoplasty case. But for this case, you can either give glasses or BTK might help temporarily. So although macular corneal dystrophy is less common than other types of stromal dystrophies worldwide, it's the most common corneal dystrophy in Saudi Arabia due to the higher consanguinity rate in our region. And it's the most common cause of the most common dystrophy requiring keratoplasty in Saudi Arabia. 3 variants of macular corneal dystrophy, type 1, and type 1A and type 2. They are distinguished based on the immunoreactivity of antigenic keratin sulfate in the cornea and the serum. Type 1 is the immunoreactive sulfated keratin sulfate is completely absent from the stroma and the serum. Type 1A is absent, but it's present in the keratocyte, and type 2 it's present at much reduced level in the stroma and the serum. So type 1 is more aggressive form. Unfortunately, the most common subtype in Saudi Arabia is type 1, which require early surgical intervention than type 2. For the management, based on Kekish experience, DARC has comparable long-term visual and survival outcomes to PKB in patients with macular corneal dystrophies. And DARC has an advantage of less endothelial rejection and less open sky complications. Schneider corneal dystrophy. So this is the one associated with systemic disease. When you look at the formal alternative names, most of them has this crystalline word. So the name crystalline is a misnomer. So in this picture showed the crystalline deposits. The name crystalline is a misnomer, as 50% actually have or don't have this visible crystalline deposits. And it is an autosomal dominant, and the gene is UBA polytransferase domain containing one gene. It's present early in the second and third decade, and it's slowly progressive. So its course is predictable. If the patient is less than 23-year-old, they present with a ring or disc-like central corneal opacities, plus minus subepithelial crystals, as in this picture. If the patient gets older, 23 to 38, they start to develop arcus liboides, and more than 38, they have the mid-peripheral panstromal haze. It's associated with hyperlipoproteinemia, and the lipid deposition usually stained with oil red O stain, as in this photograph. And it's important for if you want to stain any lipid, the fresh tissue must be submitted. So for early cases, you can do BTK, and penetrating keratoplasty can be done for advanced cases. And it's important to refer the patient to internal medicine for the hyperlipidemia management. But just remember that the hyperlipidemia management don't affect the progression of the disease, but it's important for the health of the heart and other vascular diseases. Congenital stromal corneal dystrophy, category 1. It's an autosomal dominant, and the gene is Duchenne gene. It's a congenital disease, and it's slowly progressive or non-progressive. You can see a diffuse bilateral flake-like whitish stromal opacities throughout the stroma. The corneal thickness is increased, and in light microscopy, you can see the stromal lamellae that are irregularly separated. The point to differentiate it from the endothelial dystrophy is that here the endothelium is normal, or chet, I mean chet. The endothelium here is normal, and the epithelium is normal. It's only in the stroma. Flick corneal dystrophy, you can see like a dandruff-like opacities on the stroma. زي القشرة. It's an autosomal dominant, and this is the gene involved, and it's congenital or early in the first year of life. It's non-progressive disease. Associated with many associations like decreased corneal sensation, keratoconus, cortical lens changes, and atopy. Usually no treatment is required, as most of the patients are asymptomatic. Posterior amorphous corneal dystrophy is a disease of the posterior stroma. It's an autosomal dominant. Again, the genes involved are keratocan, lomican, dicorin, and epifican gene. It's an unprogressive disease or slowly progressive disease. The hallmark of the posterior amorphous corneal dystrophy is that it is a diffuse gray-white sheet-like opacities that are more prominent in the posterior stroma. Visual acuity is mildly affected with those patients. Usually no treatment is required, and PKB is rarely performed if it affects the vision. Now we'll talk about endothelial dystrophy. Fuchs endothelial corneal dystrophy is the most common dystrophy in the West, but here is not that common. The macular dystrophy is more common. You can see the typical corneal gottata of the Fuchs endothelial corneal dystrophy. It's some of the Fuchs are category 1, and some of them are category 2, and some of them are category 3. So it's different genes, and it's different presentations. Some patients are autosomal dominant, and in early onset Fuchs, collagen type 8 alpha-2 gene is involved in this early onset Fuchs dystrophy. Most of the patients present in the 4th decade, but if the patient has an early onset Fuchs, start in the 1st decade. It's a progressive disease. However, some patients never progress. And it's commonly happen in female with a female to male ratio at 3:1, and it's staged into 4 stages. The first stage is gottata or central gottata, and that might spread peripherally. As in this picture, you can see the gottata, the black dots here in the endothelium. They are best seen with the specular reflection. And some patients don't progress to other stages. They will stay in stage 1 for life. Stage 2 is endothelial decompensation and stromal edema. Stage 3 is a bullous keratopathy, when you see the epithelium is involved now. And stage 4 is scarring and vascularization. And with the stage 4, you cannot do endothelial keratoplasty, you have to do a penetrating keratoplasty. Visual acuity usually is reduced in the early morning, and pain, some patients might complain of pain because of the ruptured epithelial bullae. This picture, light microscopy photo, showed the corneal gottata. You can see a thickened decimate membrane and the hyaline excrescence on a thickened decimate membrane. Management is endothelial keratoplasty, either DASIC or DAMIC, PKB if stage 4, and decimate. There are growing evidence supporting the use of decimate stripping only procedure plus minus rho kinase inhibitor. Posterior Morphosconia Dystrophy. It's an autosomal dominant, and if the patient presents with a unilateral disease, it's an isolated, is not associated with any gene. The genes involved are collagen type 8, alpha-2 gene, and the zinc finger E-box binding homebox gene. I know a lot of genes, and I can send you a handout of the corneal dystrophies, the summary of the corneal dystrophy later on. So often asymmetric opacities and can present as a unilateral disease, and they present with a geographic gray opacities or vesicular opacities, and some patients, they have a railroad track sign with endothelial bands. They all present in the endothelial layer. It's associated with keratoconus, corneal edema in 20% of the cases, iridocorneal adhesion in 25 cases of the cases, and high intraocular pressure in 15% of the cases. In light microscopy, you can see the endothelium is replaced with flat epithelial-like cells. Many patients are asymptomatic. However, if corneal edema develops, endothelial keratoplasty is indicated. If the patient has keratoconus, you have to manage the keratoconus and manage the high intraocular pressure. CHED, or congenital hereditary endothelial dystrophy. This is the third autosomal recessive disorder or dystrophy. The solute carrier family for sodium borate transporter member 11 gene mutation is identified in 76% of the CHID patient. You can see the thick cornea here with a slit and very opacified cornea. It's usually confused with congenital glaucoma, but you can differentiate between them with by the IOP and by the size of the cornea, and family history is important also. It's relatively stationary and it's congenital. So it's often asymmetric clouding and thickening of the cornea, and patients present with nystagmus. And if CHID is associated with hearing loss, we call it Harbonian syndrome. Light microscopy, you can see a thickened cement membrane with no visible endothelial cells. And the management is endothelial keratoplasty. Okay, now I will just talk about some tips in the management of corneal dystrophy in the last 2 slides. It's important to know that no gene therapy for corneal dystrophy at the present time, and management is based on the patient needs, visual prognosis, and extent of the corneal opacity. So it's patient to patient. You cannot manage all corneal dystrophy, all macular corneal dystrophy with BKB. So it depends on the presentation, symptoms, and the extent of the corneal opacity, and of course the visual prognosis. If the patient presents with corneal erosion, they should be treated with topical antibiotic lubricant as usual. And if the patient has recurrent erosions, many treatments can be done, like stromal puncture for peripheral recurrent erosions, BTK if it is central, or and of course you have to treat medically first before going to surgical treatment, like with lubricant, BCL, sodium chloride, and then if the medical treatment fails, you can go to the surgical treatment with stromal puncture, BTK, or with alcohol debridement and diamond burr polishing. BTK made, if the patient has superficial corneal opacities, you can do BTK for them. It's very important to exclude granular corneal dystrophy before doing excimer laser, as the procedure can cause exacerbation of the dystrophy and increase the opacification. Keratoplasty, either lamellar or penetrating, can be an option to clear the visual axis based on the extent of the corneal opacity. If it is endothelial dystrophy, you will go for a posterior lamellar like DASIG or DAMIC. Or if it is anterior opacities, you will go for anterior lamellar keratoplasty or dark, deep anterior lamellar keratoplasty. If it involves all the layers, you will go for penetrating keratoplasty. If the patient has good prognosis and the patient is really symptomatic. There is growing evidence supporting the use of Rho kinase inhibitor for the treatment of corneal endothelial decompensation, as it has been shown in mouse model that it increased the endothelial proliferation. And thank you so much.